Thank you for joining me in my discussion of how I have started using my personal health narrative to inform my teaching within medical informatics. I imagine most of you don't know what medical informatics is, so I thought it would be useful for me to first give you some definitions. And essentially, informatics is the science of information. We study how to represent information, process it, and communicate it within uh, natural and artificial systems. And in the particular application of medical informatics, the application of this to medicine. And of course, I'm sure that you're all familiar with what medicine is. And here's a couple of definitions. And I think the important point that I want to make here is that in these definitions, there's nothing about the patient or the consumer within this field. So I have been interested in for quite a while in changing that and enhancing the understanding of what a patient's experience is within the discipline. So why did I turn to autoethnography? Well, the roots of the project are uh, basically come from the situation that we find students being educated. So if you're not a clinical student like a nurse or a medical student, you're getting pushed further and further away from the clinical settings as privacy rules increase and as clinical space becomes more um, tight. And so as I was teaching students, I was finding that their experience and their exposure to clinical environments was much different than what mine was as a student, and I thought that was to their detriment. And so, in the absence of really students being able to live and observe within real clinical settings, people talk about, well, maybe we should have them watch episodes of Scrubs or maybe Grey's Anatomy for a little more drama and romance. So, I wanted to use my experience as a substitute in a sense for that. It's also, as I mentioned in the previous slide, a very clinician driven discipline, and I wanted to get more of a patient focus. And that we focus on large aggregates of patients, and this aggregation loses the meaning of an individual patient's experience. And perhaps foremost, I wanted to use history to get students to question the present as they worked on what they could envision for the future. And the ready accessibility of my own history in this motivated me to turn in this direction. It was far from a natural choice in the sense that I am not an ethnographer and I'm an engineer by training. And medical informatics has traditionally, as I said, been concerned with statistics of cohorts of people, and this idea of an N of one was certainly beat into me as something that is very bad. But I found that personally, I thought less statistically and more in what Eugenia Chang describes as mathematical thinking in terms of case studies and looking at trying to look in detail about how some particular situation works and then try to figure out if we can replicate it and make it work more widely. And so with that as kind of a permission, I went ahead and started to incorporate my own experiences into the classroom materials that I was creating. So how did I go about doing this? Okay, so I've created a simple website that I use to present some of my materials about myself to my students and then ask them questions about these narratives that relate to the medical informatics that they're studying. And at this point, I just have three, and I start with birth narrative, where I talk about what kinds of data are generated in as a community to decide to record, and use my narrative a little bit to look at how birthing has changed, and then I compare my experiences to kind of contemporary births and births of people from third world countries, etc. And so I have my little birth picture and the bill from um, my birth, and I have another one. This is I had a cancer when I was 7 years old, and I try to give them a little bit of sense of the place, how much we had to travel, and why, and how that reflected the nature of the healthcare system that we are operating in, and how is that different now, and so on. And this walks through the diagnostic process that I experienced, etc. And in each step, there are a variety of different kinds of informatics questions that I'm asking them to consider. And in addition to just presenting this materials to the student, I wanted to have the students the opportunity to dissect and question me and to have an opportunity to kind of interrogate a patient's experience directly instead of just having it be presented by me. And I thought the advantage of this from an informatics perspective is that I'm someone with a long-term patient history. I obviously don't remember my birth, but my first cancer, which I remember quite well, goes back to 1976 and have been continually treated since then for a variety of medical issues, including 3 other cancers. So I have this long patient history, and for the past 20 to 30 years, this has been blended with an informatician's eye looking at the process and analyzing the process. So what are some of the lessons I hope students learn by participating in this materials with me? Well, I hope they learn some more details about the technical aspects of medicine and informatics. I hope they get a sense of the historical evolution and what are some of the factors that influence that, and illustrate where we are with respect to where we were. Get a sense of the value decisions and what guides a patient or a provider or a family members to make particular decisions that are made. And more than anything else, give them the opportunity to reimagine what the patient experience might be and use their skills and the technologies that are at hand to transform that experience into hopefully a more positive, humane experience. So there's obviously pros and cons to this approach. And the pros, I bring health information systems to life. And especially now that I'm teaching in Australia, it provides me an opportunity to discuss the differences between the health experiences I had in the United States to what I'm having here in Australia. Illustrate kind of concretely how data are documented and communicated, and the sparseness or the richness of that record, as the case might be. And of course, there are cons. As I kind of hinted at before, generalizability. I wouldn't claim that I'm a typical patient. Who owns this narrative that I'm sharing has become an issue that has come up in multiple ways. And how appropriate is it for me to share these materials? So I will address each of these. So in regarding who owns it, my first experience with using my own self to teach goes back to when I was at the University of Pittsburgh and I was teaching an introduction to programming course, a computer programming course for the biomedical informatics students. And I created this assignment where I took a recent test that I had, a lipid battery test, and I posted the results on the course website and asked them to think of how they would take this data that is in this test result report and represent it in a computer program. And here's the actual test that I posted up to the students. You see it's very bland. I have a little bit of low density lipoprotein, but there's nothing particularly invasive or I'm exposing much about myself or anything else with this test. And you see the date and my physician and other entities being listed. Well, so the question is, whose document is this? So I, of course, consider this to be my document. It was reporting on me. It was my test. I, in a sense, paid for it. It could be considered that this document belonged to my physician, Lori Beege, and that would have been a very traditional view of who owned this document. Other entities named on the website include Epic, the software vendor that created the system, and UPMC, the health system of which the healthcare was provided. Well, the answer, as it turned out, apparently, was that UPMC owned it. At least they certainly thought so, and they were a much more powerful entity than I was. And they scanned all the university websites looking for personal health information that might have been inadvertently released. They found this website, and despite all our protests to the contrary that this was my record and it was my class, they insisted that the materials be removed from the website. So that's, kind of a simple case, but also if I think about if I'm sharing my family history, genetics, or decisions that were made within my family, then that is also sharing information about others. So my genetic and family history data is also partially the genetic and family history of my parents, of my siblings, and my children, all of whom are still alive and may have an interest in keeping that information private. Also, if I share my narrative, this reveals decisions that sometimes are poor decisions that are made by others. An example in my narrative is my ruptured appendix, which happened when I was 15. The rupture likely occurred on Monday, May 30th, yet I did not get into the hospital until Saturday, June 4th. And this is a complex combination of rather poor decisions made by my parents, by the healthcare experts that they consulted over the week via the phone, and there are reasons that this may be a sensitive material to them. What about the proprietary of sharing this information? My colleague at the University of Melbourne, Liz Malloy, has written a paper called Intellectual Streaking, where she says, and in a very positive sense, we use the notion of intellectual streaking to impart our opinion that exposure of a teacher's uncertainties, internal dilemmas, emotions, thought processes, or failures can be illuminating and valuable for learners and teachers alike. Yet they warn that, on the other hand, too much streaking may cause you to lose credibility. Overexposure can cause confusion, uncertainty, and a loss of face. Well, this medical streaking, if I share my medical records, can really lead almost to what I am calling virtual streaking, in that if I provide a CT scan of myself, this is one that was acquired recently in Australia, I can be literally stripped down to a presentation that would be considered inappropriate if this were live. Similarly, there is just some information that may be uncomfortable or sensitive to others. So here is my bill from my birth in 1968, and I provide this to my students along with the coding to ask them to identify what are the examples of demographic, administrative, and clinical data. And if they are diligent students, of which most of them were, they will see that this code 905 and the charge of $5.50 refers to my circumcision. Have I found my own limits in what I'm willing to share? Well, I certainly initially found this idea of sharing my circumcision bill uncomfortable initially, although I got over it. There are things that I have been unwilling to share. The impact that my health experience has had on my sexual well-being, for example, the role of my religion in me wrestling with these events over the course of my childhood and adulthood, and a variety of dermatology images, which for obvious reasons are more difficult to share. How have my students reacted? Well, I have a very diverse cohort of international and domestic students here in Australia. And to me, being just very recently relocated from the United States, they are all international students. And I am not sure of what their prior expectations and what they view as appropriate, etc., are. But I have not received any complaints from the students. The assignments were engaged in a very responsive manner by the students. Their submissions were great, and due to COVID-19, there has been very limited course assessment here in Australia, and so I didn't really have the opportunity to drill down more detail on what they thought. So in conclusion, this is a very early experience for me. I do find that it is enriching for the students, and there's a lot of work yet to do. And so in this, I want to thank you for getting in my head and sharing my thoughts with me about teaching using myself. Thank you.